What would you consider other good reasons for low carb or ketogenic diets, other not as good reasons, and then perhaps some contraindications?
Yeah.
So that kind of brings the question, you mentioned people think they're kind of low carb. What would you consider low carb? Is there a specific cutoff, like 30 grams, 50 grams? Yeah.
Yeah. We as humans love to categorize and create criteria and thresholds. The fact of the matter is, biology and physiology doesn't give a crap about the cutoffs we generate. So what I would say is that standard in the literature for quote low carb is less than 130 grams per day of net carbs or less than 20% of your kilocalories from carbs. And then a ketogenic diet's typically defined various ways, but maybe less than 10% of energy from carbs or less than 25 grams of carbs per day, or if you demonstrate nutritional ketosis. Point being, there are lots of different ways to define it. And then also, on an individual level, with respect to the physiology, it's really relative.
Yep.
So 100 grams of carbs for me is not the same as 100 grams of carbs for Sean Baker, who's 6'5" and 260 pounds. If you can't see me, I'm literally half the man he is in terms of just pure body mass. So like, how muscular are you? How much activity are you doing? If you're an ultra runner and you're eating, 80, 100 grams of carbs, that could be keto, but it's not going to be keto if you're sedentary. So
Yep.
all these things need to be taken in context. You can put cutoffs for the sake of categorizing things in the literature because you kind of need to. Say you're going to group studies and do a meta-analysis. You do need a standardization. But on an individual level, it's really ask the question, what is your use case? And, what are all the other factors that would influence the impact of those carbs on your physiology? Are you very big and muscular and active or not? What is your overall energy intake? Those kind of questions. So sorry for a kind of hand-wavy answer, but that's the honest answer.
Yeah, that's a great answer. And that's what I've seen with my phenotype as well. Extremely active, CrossFitting and functional fitnessing my life away. And I probably weigh between 230 and 240 most of the time. So yeah, if I partition my carbohydrates right, I don't think my fasting insulin's ever been above 3. And regardless of what I do, even when I do have, a couple 100 grams of carbohydrates, it's my CGM data does not react how it would if you gave that diet to the average American. That's a
Yeah.
point for individualized medicine, I guess. So I guess we've kind of talked about some reasons for low carb or ketogenic diets. What would you consider other good reasons for low carb or ketogenic diets, other not as good reasons, and then perhaps some contraindications?
Yeah. I would say there are a lot of good reasons for trying a low carb and ketogenic diet. I think that there is unique benefits, or let's say enhanced over other interventions benefits for diabetes and obesity. You do get a metabolic advantage from a ketogenic diet in terms of weight loss, even beyond appetite control. But a point that I always like to make is that a ketogenic diet or a low carb diet is not a weight loss diet per se. You can use these diets for, even if there aren't RCTs, inflammatory bowel disease. There's now emerging literature for not just epilepsy, which was the ketogenic diet's initial main use case, but now other neurological diseases, Parkinson's disease, Alzheimer's disease. There was just a big trial you probably saw circulating around Twitter out of Stanford on ketogenic diet for schizophrenia and bipolar.
Yep.
That came out of Shibani Sethi et
Even
al.
benign
And
brain tumors, my understanding.
yep, brain
Yep.
tumors in combination with like chemotherapy for things like glioblastoma, autosomal dominant polycystic kidney disease.
Hmm.
There's so many things that now it's being explored for. So, a wide array of things. I think in terms of contraindications, I mean, it mostly would be if you have a particular genetic mutation that would cause you to react adversely to a high-fat diet, or if um, serious adverse consequences develop. There are, you can just look them up. I don't have them memorized, but just particular polymorphisms that are relative contraindications to ketogenic diets. I
Mhm.
wouldn't say there's an absolute contraindication for like for being in ketosis, let's just say. But if you have a fat processing defect, then you probably shouldn't eat, you know, a ketogenic diet. But it's like this for any food. Like if you have alpha gal,
Yep.
let's say you get bitten by a Lone Star tick and have alpha gal, you probably shouldn't eat meat. But that's kind of like a rare thing. So there's not a ton of absolute contraindications in
I
terms of just like, yeah.
I know this is also kind of debated. What about for example, type 1 diabetics or type 1.5 uh, diabetics?
Andrew Kutnick will be the guy to talk to about that, but I think that they're now doing research specifically on that and finding efficacy. I mean, by definition, if you have type 1 diabetes, you're not generating insulin or you're generating very little. So it's not going to be the kind of thing that would very easily get you off insulin, but
Mhm.
it could have benefits. It might have something to do with reducing, an autoimmune reaction. I think from my understanding, the main benefits would come if you adopted very early on in the disease process,
Yep.
because maybe you still have some beta cell reserve. There are other things that might be going on that we don't necessarily fully understand well, or maybe I don't fully understand well, maybe it's understood, but say with glucagon inhibition. So in type 1 diabetes, because you lose the beta cells, and the beta cells are next to the alpha cells, which make glucagon,
Yep.
then there's a lot of glucagon release, and low carb diets. I don't know what, I'm pretty sure in type 1 circumstances as well, though, they'd increase GLP-1 area under the curve and inhibit glucagon. I know that there are other things that they've looked at to attenuate the glucagon response. But yeah, there definitely are some data on it helping type 1. Type 1 is not a contraindication. Let me put it that way. And I definitely know type 1s. Now we're back in the realm of anecdotes, but like who go keto, and there might even be literature on this too, but like not only are they more stable, but they're having fewer hypos.
Yep.
So the concern will be just on the surface of it, type 1, they're not eating carbs, therefore they're going to go hypoglycemic. And that's obviously a big concern for type 1s. I think that actually that tends to happen less and less as type 1s get fat adapted. But you'd have to talk to someone with expertise in that area, because I definitely don't want to misspeak on this, and definitely don't want anybody listening with type 1 to take this as, oh, Nick says I don't need
Yep.
carbs, let me just go keto immediately. That would be a disease condition where you definitely would want a lot of support in transitioning,
Yep.
because your body may react adversely at first if you don't do it the right way.
Yep.
As some people don't do keto the right way, they're like, they get the keto flu, their electrolytes are out of balance, they get a little headache. You,
The,
yeah, you don't want to
yeah.
screw around with your blood sugar too much if you have type 1.
The kind of the how I started thinking about that is thinking about type 1 diabetics that are very proactive with their health, and also thinking about an endocrinologist, which I previously referred to. But now I've gotten a couple of his patients that have been in DKA. But long story short, if you take an SGLT2 inhibitor, which makes you pee out glucose, uh,
Hmm.
if you're a type 1 diabetic, then it is important to monitor urinary ketones, because there's a risk of something called euglycemic DKA,
Glycemic
or
DKA.
euglycemic diabetic ketoacidosis. And ketogenic diets probably do not increase the risk of euglycemic diabetic ketoacidosis significantly.
Hmm.
But like you mentioned, many scientists and clinicians are studying that. So perhaps that's another podcast we'll have in the future. I know we've had one
Yeah.
specifically on type 1 diabetes that Cameron can link in the description for anybody that happens to have type 1 or have family and friends with type 1 diabetes. But yeah, if anything, the downside might be if you're doing urine ketone strips
Hmm.
in order to, because a lot of people, if they test a positive urine ketone strip, they'll stop their SGLT2. Um,
Yeah.
so that's something to potentially consider. But yeah,
I,
talk with
I,
your doctor or endocrinologist about that, but to make sure he or she is well versed in kind of like
Yeah.
additional therapies for type 1s. Bigger thing on the future for type 1s, not to completely rabbit trail, is the amylin, long-acting amylin analogs.
Yeah. There's a lot of innovations in this space. I've only heard of euglycemic DKA with SGLT2s
Yep,
because you have like an insufficient insulin response. I've never heard of it with a ketogenic diet.
that's the only patients I've ever seen with euglycemic DKA is patients on SGLT2s every single day, and they're all from the same physician, which I talked to, and he said, "Oh, it doesn't happen." I don't have my patients check ketone strips. So
Yeah.
famous last words, I guess. But and that's another sign that even if you're a specialist, you should continue being a lifelong learner.